All right, now we move on to our third panel of the day. Our third panel is Dr. Mohammad Hafiz Sakan. He was graduated from Cardiff University, UK, specialized in emergency medicine at UKM, and a fellow of emergency critical care. He is emergency physician from Emergency and Trauma Department of Hospital Melaka. He is also active in publication related with emergency and trauma. So there's a small fact that I'm sure not everybody knows is our doctor here was a GQ model of the year. Not mentioned which year, but his winning is for the best swimsuit category. So guys, I think maybe Google can help us for this. Anyway, the title is Toxidrome, Toxic Thingy You Need to Know. Please welcome our one and only Dr. Mohammad Hafiz.
Assalamualaikum warahmatullahi wabarakatuh and a very good morning. I hope you guys can hear me well.
Yes, doctor, very clear.
Okay, thank you so much, Mr. Chairperson. First of all, thank you for the kind introduction. Before I start, I would like to add something when Azma answered the question, a question posted by one of the participants. Okay, in the near future, in the ED, don't be surprised if we find ED ICU beds. In other words, in the next frontliners, I mean, in the future, you might expect to find ICU full capability beds in ED manned by ED itself. Okay, so in other words, by that time, all the paramedics, doctors, and everyone involved should know, again, how to manage intubated patients and to all the care throughout until the patient is weaned off. So to add on to that, so that's why all the paramedics and all the staff should be prepared, should get themselves prepared for that eventualities. So without further ado, this is my topic given to me: Toxidromes, toxic thingy you need to know. Okay, so I'm speaking from Hospital Melaka studio. So I hope the line is clear, but if you find difficulties, you can just intervene. Okay, so before I kick off, I would like to bring you guys to the story of Romeo and Juliet by Shakespeare. So I'm sure you all know the story well. So basically, as you can see, towards the end of the story of Romeo and Juliet, so Juliet consumed some poison and to fake her death. So eventually, Romeo, upon knowing that his lover, being a lover boy he was, that Juliet died, so he went to see Juliet on her deathbed, and you can see the forlorn look on his face. He was touching his chest because of the utter sadness, and being stupid as he was, he killed himself. And then later on, in the end, Juliet woke up from her fake death or fake sleep and noted that Romeo has died, and Juliet lived happily ever after. So basically, it was believed that Juliet might have swallowed moderate amount of Atropa belladonna, or the name, call it the deadly nightshade. As you can see, the deadly nightshade has got quite distinct, beautiful flowers and some nice purple-colored fruits. So this Juliet developed Anticholinergic Toxidrome. So as you can see, Romeo, you can see the look at his face that, some disbelief, but I think he was also puzzled looking at his, the dead Juliet. He knew that something was wrong, but then he knew that Juliet committed suicide and then he killed himself off. But only then, if Romeo knew that there's such thing as anticholinergic toxidrome, he would not have committed suicide, and they would have happily ever after getting married and so on and so forth. So my point, my moral of the story is, # don't be like Romeo. Know your toxidromes. So you might save your patients, and you might save yourself in some circumstances. So toxidrome. So what we mean by toxidrome? This is alias toxic syndrome. So this term was brought by Morfensen and Greenshare back in 1970s. So basically, toxidrome describes a group of symptoms and signs and or characteristic effects associated with exposure to a particular substance or class of substances. So it's a group, a constellation or collection of symptoms and signs that you get from a particular substance that you consume or might have had. Okay, so this is analogous or similar to, as you can see, the acute coronary syndrome. For example, if somebody comes to you with heart attack, we know that there's a blood clot in your coronaries. So because of that, there's ischemic and infarcted. And because of this, patient get chest pain, which tend to be ischemic in nature. The pain radiates to the arm and shoulders. And at the same time, if the patient has got, pulmonary edema, he might have shortness of breath. And maybe because of the shock itself, he became cool and clammy at the peripheries. He might be nauseous, BP low can cause his lightheadedness. So all these are the collection of signs and symptoms because of the myocardial ischemia or infarction due to the acute coronary syndrome itself. So the toxidrome is analogous to these pathophysiological changes that you might see in such example in ACS. So when you approach to the poison patient, you know that the patient has been poisoned. So some people like the mnemonic of resus, RSI, dead. So what it means is that resuscitation, we followed as usual, the airway, breathing, circulation, and then we seizure control if the patient is seizing. So this is due to the fact that quite a large number of toxidromes can present as seizure as well. So you correct hypoglycemia, you correct hypothermia, and also if you think strongly because of this one toxidrome, you might want to consider giving antidotes during the resuscitation phase itself. So later on, you perform the risk assessment. So risk assessment is based on the cognitive or the experience of the treating healthcare providers. For example, if you think that the patient is taking like paracetamol, you might know that within 6 hours, there's a safe period before you can prescribe NAC. So you know that if the timing is correct, you might want to perform the test after 6 hours. And you provide NAC there on if the blood levels is at the toxic level. Later on, you provide supportive care and monitoring. You perform the indicated investigations and screening, ECGs, and you do some specific investigations that's indicated. And in some instances, you perform decontamination, enhanced elimination. And again, later on, you prescribe antidotes and dispose of the patient off. So in other words, your management throughout the steps and throughout the process is guided by the differential analysis that you have, the specific poisoning that is occurring in that particular patient, the complications that require specific treatment. Of course, knowing this complication might be caused by the particular poison that has been taken. And also the correct indications for decontamination, enhanced elimination, and indication for antidote. Without knowing this, the particular toxidrome, you cannot perform all this. And in other words, you cannot perform proper resuscitation of the poisoned patients. So knowledge of the classic toxidrome provides sound framework around which to initiate evaluation, stabilization, and treatment of the vulnerable poison patients. So you have to have sound knowledge of at least the toxidrome. Okay, approach to the poison patient. As you can see, there's a cartoon diagram that nicely depicts all the signs and symptoms that you have to pick when you see or when you attend to these particular patients. And most importantly, a good physical exam of a poison patient include all these parameters, looking at the eyes, especially the change in the pupils. You shine the light on the eyes to see if it's dilated or constrict on light response. You look at the lungs, you listen to the lungs. Is it sound of the lungs is normal, is clear? You have to count respiratory rate because some toxidrome might present as bradypnea, which is the low rate. Look at the heart rate and count it. Okay, skin, touch the skin, okay, see if it's hot or cold, measure the vital signs, is the blood pressure, is it normal or is it high or low, listen to bowel sounds, and look at the temperature. So take note of all the abnormalities that might be present in your poison patients. And this group or the constellations of signs and symptoms help guide you to point to the possible toxidrome that the patient is having. So you can see down the vital signs. The vital signs in this case are not just to assess and monitor over time the status of the patients. It also, these vital signs also provide valuable physiology clues to the underlying toxicology. So these are the major toxidromes. If you read the books, if you read the literature that describe toxidromes, okay, we have the cholinergic toxidrome, anticholinergic, serotonin, sympathetic stimulants, the opioid narcotic toxidrome, the ethanol or hypnosedative toxidrome, the alcohol withdrawal toxidrome, and opioids withdrawal toxidrome. So we describe it in better details. So if you look any literature that describes these toxidromes, they almost all the time they post a table. So you see all the groups of toxidromes there, and then they provide all the changes in the blood pressure, pulse rate, respiratory temperature, the mental status. Almost all will be describing their mental status because they make huge impact on the types of toxidrome that the patient might be having. The pupil size, okay, the bowel sound, okay, sweating or not, okay, other features that might point towards the toxidrome itself. As you can see, these tables, they are quite, it's quite difficult to memorize. Me myself getting old, so I almost forget reading all these tables. I'm not promoting books, but there's one nice literature book you can also buy in the internet, the Toxicology in a Box. I mean, somebody clever out there, they make nice illustrations, cartoon illustration, and simplifies all these toxidromes in a book. So have a look at this book. And most of the features or most of the posters that I present in this presentation comes from that book. So first of all, we have this anticholinergic toxidrome. So if you look at the cartoon, you can see there's the man with the big hat. You know that the character of Mad is a Mad Hatter, and the bat on the top, and he's standing on a desert which is hot, full of cactus, and you can see that the mouth, the tongue is protruding. So imagine this man, and then you have to imprint this image inside your brain, and you can see any patient with anticholinergic toxidrome, you will see all these features printed on the patient as well. So what does this anticholinergic toxidrome describe? Okay, to understand all this anticholinergic toxidrome, or any toxidrome for that matter, we have to look back at our autonomic nervous system. So we have the sympathetic and parasympathetic. The sympathetic and parasympathetic in the normal physiological state, they work hand in hand. So in other words, if there's a ghost attacking me now, I'll be having more of sympathetic because now I'll be at the flight and fight response. So I might run away or I might fight the ghost. If I just had nasi lemak just now, so I might be in more like parasympathetic mode, whereby I rest and digest. I will digest my food and my eating to conserve my energy. So in the normal physiological state, this sympathetic and parasympathetic work in hand, and any alterations is because of the needs that arises. So as you can see, okay, so this is the neurons, that is sympathetic pathways and the parasympathetic pathways. As you can see, it uses different chemicals. The sympathetic mostly uses the norepinephrine or noradrenaline. The parasympathetic at the end, or these muscarinic receptors. And in anticholinergic poisoning patients, okay, something block the muscarinic. So in other words, their parasympathetic is down. So in other words, the sympathetic is unopposed. So mostly the patient will be in the flight and fight response. So as you can imagine, if the ghost is now attacking this patient, like every time, of course, he's going to be like in this feature, isn't it? So what happens to him, okay, or the patient? So the patient is going to have like flush red skin because now the skin is red. The patient will be blind as a bat because if you look at the pupils, it's going to be dilated. And when big, like 8mm size. So when you try to shine the light on this pupil, it won't constrict. Why? Because now the parasympathetic is blocked. Okay, so they have dilated pupils of mydriasis, and it won't respond, it won't go constrict upon your light. Okay, so they also met as a hatter, like confused. They're confused because of the central effects. Okay, they have a dry mouth because now the salivation is reduced. It's inhibited because of the sympathetic unopposed. Okay, so when they talk, they have something called a cotton dry talk, like ha 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 ha, because the mouth is so dry. Okay, they are hypothermic. Okay, the temperature is high when you take the temperature. And if you look at your patient that in front of you, is the patient will be maybe like, lying on their bed. They are trying to hold on to something and they're shaking. They will take their ECG off, they take off their clothes, and you can see the hand try to grab something because they are hallucinating. And that's quite a typical feature of a patient who is having anticholinergic toxidrome. They're tachycardia, but they have absent bowel sound if you listen to the bowels. So these are the features that you can see from the anticholinergic toxidrome itself. So what agents that can cause this? These are various agents. If you can see the Jimson weed or the datura. Some medications, the antihistamine, can also do that. The physostigmine is a drug that you give for cholinergic conditions. Some drugs, eye drops, and also some medication that they give for vertigo. Okay, so these are the features of the anticholinergic toxidrome. Next is our cholinergic toxidrome. Okay, when you look at the cholinergic toxidrome, try to imagine the patient is sitting on a toilet bowl, having a diarrhea and pee a lot. And if you look at the mouth, they're vomiting, they're profuse salivation, they're crying, lacrimation, sweating, they're wet. Okay, some people even describe them as the SpongeBob SquarePants. The sponge, the wet sponge, if you squeeze, all the water will come out. So that's how the cholinergic toxidrome patient looks like. Okay, so I'm sure you know the story. I'm sure you've seen this over and over in YouTube. Incident that happened, quite sad.
And horrifying scene from a suspected sarin gas attack in northern Syria today. In a conflict that is increasingly challenging for reporters to cover. Children struggling.
Children, when we arrived, they have pinpoint people, drowsiness, agitated.
So as you can see, quite a sad event, of course. And then the doctor tried to describe the toxidrome there. So what he was describing was actually the cholinergic toxidrome. The patients was, hypersalivating, bronchoria, pinpoint pupils, and this was due to the sudden attack that happened in Syria last time. Okay, looking again at the autonomic nervous system. Now, in cholinergic toxidrome, what happened was the agent or whatever chemicals that was given caused increase in cholinergic stimulation. So meaning that there are a lot of muscarinic effects of the parasympathetic pathway. So all this parasympathetic will go up. So more like rest and digest stuff. So you get all of these manifestations in your patients. So the muscarinic activity predominates. So you get, as you can look at the books, the sludge and the dumbbells mnemonics, the killer bees as the bronchoria, bronchoconstriction and bradycardia. So this is what initiate us to give the IV atropine. So in our country, in our settings, most of the time, people come to you after they quarrel with their boyfriend or girlfriend or husband and wife. They consume the organophosphate, the Latihan, organophosphate pesticide, the Carbamet pesticides. These were typical in our setting. We have the V8, VX in the airport. I'm sure you know the history. So that's one of the organophosphate gas attack, and some of the Alzheimer's medications and also some mushrooms, the muscarine type, can cause these cholinergic problems. Okay, how about the serotonin syndrome? Okay, serotonin syndrome. As you can see from the poster, you can see that there's a lady there being tied on the bed. Okay, she's sweating. They call it the wagging wet dog appearance. She's grinding her teeth. She looks like agitated and she was trying to break free, but she cannot because people tie the legs and there's a hyperreflexia there. Okay, at the same time, you have this, again, the old man from the Anticholinergic Toxidrome. Why? Because the serotonin syndrome and anticholinergic might be similar in presentations, but he was trying to say something there. He said, similar to anticholinergic overdose, however, this has diaphoresis, nausea and vomiting, while he, or the anticholinergic, was dry as a bone. She's wet, she's hot and she's profusely wet. Okay, this is how you differentiate between serotonin syndrome and anticholinergic syndrome. So in terms of mental status change, in serotonin syndrome, you get confused, agitated, lethargic, and then later on in worst case scenario, coma. They have the autonomic instability. Okay, again, the pupils dilate, they can have dilated pupils, mydriasis. Okay, so again, they describe the triad of neuromuscular hyperactivity, hyperkinesia, hyperreflexia. Clonus is very strong, is a very pathognomonic of serotonin syndrome. Okay, so these are the causes of serotonin syndrome. So basically, in our brain, we have serotonin pathways at the raphe there, and this is, as you can see, the serotonin receptors. Okay, so we have about 14 to 15 serotonin receptors in our body throughout, but the ones that is responsible for certain syndromes are the 5-HT2S and 5-HT1S receptors. As you can see from the diagram, this is how the SSRIs, the MAOIs, people try to modulate the neuropsychological input or pathways, and this is how they prescribe all these antidepressants, you see, the mood-changing drugs, and this is what the doctors or the psychiatrists try to do. But at the same time, we also have this pathway caused by psychedelic drugs that the patient can take, like all the other crack cocaines and stuff like that is from this pathway. So, but they forgot that even though serotonin is present in the brain, there are a lot of other serotonin can also be found outside the central nervous system. And these are the ones that modulates your cardiovascular functions, your bowel functions, your bladder control, even the platelets. So when they have a lot of this excess stimulation of these serotonin receptors, you begin to get all these symptoms. Okay, so excessive of serotonin can result into this. If you look again at this the diagram, this cartoon lady, you will find a similar resemblance to this this particular lady here. So this is basically a very important history in the US, and the author tried nicely to depict that by describing her inside the poster. So this is Libby Zion. Libby Zion, basically, she was taking MAOI or antidepressant. She was like 23 when the incident happened. So she was that antidepressant and she took cocaine. So after that, she complained of severe abdominal pain and she went to the ED. So she went to the ED in New York. So she was there, she met the healthcare providers there. So they did not know what happened to this patient. And nicely, they prescribed pethidine for the abdominal pain and they put her to rest. So pethidine is meperidine group or demerol group. Okay, so what happened was the symptom got worse. Okay, and then she began to be more aggressive. And because of that, they had to tie her down. Okay, so this particular photo depicted that you can see that she's peeing, she's vomiting, she's peeing in the pants, she was struggling. This caused further distress, and she was so hypothermia at the point where she developed temperature was 42, and later on she developed cardiac arrest. And whole and behold, the father was a famous lawyer in New York, so they began the investigations, and hence, because of this, they diagnosed, they found out that she actually was having Throttling Syndrome. So the doctors and the healthcare providers who treated her at the time did not know what actually happened to her, because she did not consume a lot of this MAOIs in large amounts, but it's more like recreational cocaine, which she normally took. So because of this, they made a law. They call it the Libby-Zion law. So this changed a lot of practice in the US in terms of the medical legal is being performed, and also the working hours of the healthcare providers that should, of course, people got sued because of this case. So the point of thing is that in these kind of cases, they are commonly due to drug interactions. In other words, some GPs might prescribe the drugs, might not know the interactions of this serotonin activity might be enhanced, and rather than acute consumption of large amounts of poison or ingestion. So in this Throttling syndrome, so the increased serotonin activity, not because of the amount of serotonin that she's taken, is because of maybe one thing, the drug can limit or slows down the elimination of the previous drugs, the MAOI that she was taking, or maybe some agents that might be, having similar characteristics that like serotonin neurotransmitters. And this present in a spectrum of symptoms. In other words, they can present with clonus initially, or they might present with just hyperreflexia and tremor and some agitation when they present early. And later on, they can present in a bad shape, in coma and hypothermia, a full-blown Throttling syndrome. So this drug, they also include the 6 hours onset. In other words, this is a huge clue. For example, when you try to diagnose Throttling syndrome, the patient might have changed the dose of the medication that the patient was taking, or maybe add on other drugs, and it was like 6 hours before that. So it's a big clue, because there are some conditions like baclofen withdrawal or NMS, so they don't have these particular features. Okay, so if you see this patient, if you happen to encounter the Throttling syndrome, you see these features, and it's quite important to recognize. This is called the ping pong gaze. The eyes are like playing ping pong. Okay, if you play ping pong, you hit on one side and the ping pong ball goes to the other side. So similar. And when you look at the eyes, it goes bang bang side, and then it goes all the way around. So this is called the ocular clonus or ping pong gaze. So even if you want to intubate patient with syndrome, you look at the eyes will behave like this. And this is typical features of ocular clonus that occurs in Throttling syndrome. Okay, next is the Sympathetic Oxygen. As you can see, somebody is on the stake. Okay. And if you look at, again, our autonomic nervous system, we're trying to understand what actually happened to this patient. Okay, so the patient may have hypothermia, bowel sounds normal, tremors is quite significant, blood pressure can be high, again, at the grinding of the teeth, at the bruxism as we call it, sweating, mydriasis, again, dilated pupils. They have flight of ideas, psychosis, paranoia, they overthink, overstress, they overworry. Okay, they're tachycardic, and they have breakdown of muscles abnormalities. This is because patients with sympathetic toxidrome, they tend to overdo things. They lost their inhibition of trying to. They can do extra. For example, they have the superpowers because why? Because they loss of inhibition to protect their muscles. But as a consequence, they might have a lot of damage, breakdown of their muscles. They can cause abnormalities in this case. So what actually happened? So in sympathomimetic toxidrome, we have a lot of sympathetic action. Okay, this is because of the direct action or reuptake or inhibition or increased catecholamine release or the delay of the breakdown of these neurotransmitters, causing a lot of sympathetic action. So you get big sympathetic, we get again big fight and flight response because of this action at this junction. Okay, so the pupils, as you can see, is dilated, but to differentiate between sympathomimetics and the anticholinergics, okay, if you shine lights on the pupil, even though the pupil is huge, when you shine light, it constrict. This is because the parasympathetic is not blocked, like the ones in acetylcholine, the anticholinergic toxidrome. So that's how you differentiate these two. Okay, and what are the agents or things that can cause this? So the ice, the amphetamines, MDMA, the crack cocaine, bath salts, ephedrine, epinephrine, okay, all these agents can cause sympathomimetic toxidromes. Okay, so hypnosedative toxidrome is the next one. Okay, so hypnosedative toxidrome is drugs that cause both hypnosis, cause you to sleep, and sedation at the same time, or to calm you down at the same time. Okay, so looking at this, I hope you won't fall asleep, but it's very importantly what effects they can have on the body system. So as you can see, the cartoon there, dancing on the dance floor, and then see double vision. Okay, even though that she's ugly, she might think that she's very pretty, and the eyes might have nystagmus, confused, and forget of what the incident was. So this is very important. Okay, and what happened was mostly the CNS depressant take effect. Okay, for example, like alcohol. Again, alcohol is a frequent co-injections, and this potentiates effects of these hypnosedative drugs. Okay, the Gaba receptors is the most common or the inhibitory receptors in our nervous system. Basically, the chloride ions that pass cause inhibition to most of the excitatory pathways. So as you can see, these are the agents that can cause hypnosedatives, the so-called the MPECCA cocktail, the chlorohydrate plus the other drugs. Okay, MPECCA is a very important history, again in Chicago last time, the so-called nefarious bartender. So this guy runs a bar in Chicago, and what happened was he dropped them, he put something in their drinks, and then the patron or the customers fell asleep, and then they robbed them in their pickpockets. And then later on, the customers, of course, forget as to what happened. So they did quite in large number of cases, and later on, it was found out that he used this hypnosedative agent. So it was quite a significant history because of this, and then later on, we know about the dead weight drugs, the rohypnol, for example. Again, very famous last time. So this drug again caused amnesia to their victims, so they can wake up. They don't know what happened to their bodies afterwards, and not knowing that they've been raped. Okay, so these are the other agents: the barbiturates, the chlorohydrates, the GHB or the red drug rohypnol just now. Okay, the benzodiazepine, similar compound. Okay, so this can cause hypnosedative toxidrome, and treatment mostly supportive, and over time they will recover by themselves. So that's hypnosedative toxidrome. Again, next is the opioid toxidrome. As you can see, somebody lying on the ground, the slow-mo. Okay, so if you look at this patient or victim, there's a possible track marks, abscesses from the skin. Okay, so possible rhabdomyolysis because it's been lying down for too long. So there's a muscle breakdown, and also a compound syndrome because of the compression of these muscles. Hypotension, BP goes down, hypothermic, okay, because it's been lying out for too long. Okay, so decreased respiratory rate. Okay, decreased respiratory rate is very important. Okay, in opioid toxidrome. Okay, so what compound can cause this? So the narcotics and its derivatives for the being important in the US, for example. So they got pethidine, the methadone in our part, heroin, fentanyl, and morphine. This can cause opioid toxidromes. Okay, what happens is in our normal brain, we have these endogenous opioids, the endorphins and enkephalins. So basically, this is what controls our mood and everything. So in good amounts, we are as as nice and maintain our physiological status. But if you take all these exogenous opioid, they are going to be like this. The purple ones are the exogenous, or the outside source of this agent that can act on your opioid receptors in your brain. And this can cause a lot of adverse reactions. Okay, so in toxidrome state, so you expect to have bradypnea. So I highlighted it because it's quite the prominent feature in this toxidrome. Why? Because normally, in terms of if somebody has got normal physiological response of their brain, if somebody is hypoxia, because of the strong respiratory center reflex to this low oxygen state, the brain will instruct your lungs or your respiratory system to increase the respiratory rate. It's such a powerful reflex or positive feedback that try to maintain normoxia in our body. So if somebody has consumed a lot of having this opiate toxidrome, even if the patient is hypoxic, the reflex in the brain is so blunted that there's no positive feedback from the respiratory centers. So and at the same time, you have reduced rate down to less than 10, for example. So patient typically they are hypoxic, at the same time their respiratory rate is low. If you look at their pupils, they are pinpoint, small, okay, or meiosis, okay. So they're bradycardic, okay, the hypotension and hypothermia. So this is how meiosis or pinpoint pupils look like even, okay. So knowing that, for example, in the US or in some third world countries, this has been indicated in their CPR guidelines as well. Because why? Because knowing that opioid toxidrome is rampant, especially in the streets of the US and some countries like UK, they have to give naloxone, or this naloxone basically is an antidote to reverse the effect of opioid toxidrome. So as you can see, if you suspect the patient is having opioid toxidrome, you start CPR, you give this injection, IM naloxone, you start CPR and look at the response. If you see any response, okay, and then you monitor them. If the patient going back to unresponsive, and you have to start in CPR and apply your ED and give another naloxone. Okay, this is the naloxone that injectables. Okay, this is the generic naloxone that they can buy in the US, and they can also get intranasal naloxone spray. So I mean, all these addicts, opioid addicts, okay, they can buy over the counter naloxone just in case if they develop this opioid toxidrome. Okay. So for paramedics, I'm sure back here we haven't had this pandemic of opioid or toxidrome occurring in our streets yet, but bear that in mind. It might happen in the future, and you might have to actively give naloxone to them. Okay, just now it's opioid.
Hello, doctor. Sorry to interrupt.
Yep.
Okay, you have another 5 minutes.
Oh, 5 minutes. Okay, I'll be quick.
All right. Thank you.
Okay. All right, so we have opioid withdrawal toxidrome. Okay, just now it's opioid toxidrome. It's the opioid withdrawal toxidrome. So you can see that this from this cartoon, somebody's lying on the sofa, vomit, urine, diarrhea, and then they have all these typical bumps, goosebumps on the skin. This is what we call the cold turkey, and the abdominal cramps. They're kicking because of the kicking habit. Okay, so opioid withdrawal is the hyperaromatic state occurs after abrupt cessation. They want to stop this for opioid dependency, so they stop immediately. So this is what happened to them. Okay, so you get initially incessant ataupun non-stop yawning, like this one. Okay, so this opioid withdrawal usually after 12 hours, the last opioid being taken. And but even though it's a bad experience, it's usually no little potential that occurs in opioid withdrawal. The effect can last up to 24 to 72 hours. And but in our setting, most common scenarios would be like, somebody has been caught by the police. They were put into the lockup or jails, and after spending 2 days not getting the drugs that they normally take, they go into cold turkey. Okay, so you can, as you can see from the features, and you can also see that the cartoon, there's a baby on the ceiling. Okay, so but why is there a baby on the ceiling? Okay, so I think the cartoonists try to nicely depict the scene from the transporting. I'm sure you've seen the movie Transporting before, and this So as you can see, it correctly depicts how opioid withdrawal would look like. You see the sweatiness and the goosebumps, and then the manic or the hallucinating, seeing babies on the ceiling, and it's horrendously not a good experience. But that's how opioid withdrawal looks like. Okay, lastly, the alcohol withdrawal. So you can see some people, like the mnemonics, had scenes. The hallucination, anxiety, tremors, with the pulse, sweating, insomnia, nausea, vomiting, and so seizures towards the end. As you can see from the guy there, okay, he was sitting up, okay, his sleeves are up, he got all the antsy bits there, climbing up his legs. But of course, these are all hallucinations. Okay, sorry. Okay, and REM fits. Okay, so basically, alcohol withdrawal, there are a few stages of alcohol withdrawal, but it can occur as early as 6 hours after stopping this alcohol. These are the mild symptoms. So what you see, you get anxiety, headaches, non-specific symptoms, nausea and vomiting, insomnia, and mild tremors. These are uncomplicated. Later on, as it gets severe, so you get hallucinosis, and you're hallucinating. You see pink elephants, as they call it. You see the formication, the feeling of like ants climbing on you, okay, pinching on you. These are the so-called formication that they normally get with alcohol withdrawal. Okay, and later on, okay, they have this REM fits. REM fits basically describe the seizures that can occur in alcohol withdrawal, and this can occur in 10% of the cases. That this can occur after 12 to 24 hours stopping the alcohol itself. Okay, and worst case scenario, they get this the delirium tremens. Okay, in delirium tremens, you get confusion, you can get fever, you get severe autonomic changes and persistent hallucinations. Okay, it occurs in 5% of the cases. So basically, what happened is in alcohol withdrawal, they've been consuming alcohol for too long. So you know that alcohol acts on your Gaba receptors. So if you take too much of alcohol for a long time, so the nerves, the brain thinks that there are a lot of inhibition going on. So they are down-regulating the GABA receptors. So lysosomes now absorb the GABA out. Okay, so you have less GABA receptors. So when they stop abruptly, okay, so as you can see, there are a lot of excitatory or sympathetic action going on. So that's why it says all gas, you press on the gas in your car, but no brake. So you go like 100 miles per hour, but no stopping. Okay, so that's what happened in alcohol withdrawal. Treatment will be benzodiazepine. Okay, so of all that toxidromes, if you can't remember all, of course, but if you can remember only one thing, so these are some of the keys of the key features of this toxidrome. If it's anticholinergic, hot and dry with mydriasis. Okay, so mydriasis is opposite of meiosis. As you can see, mydriasis is big pupils. Okay, mydriasis is big word, long word, big pupil. Meiosis is small word, small pupil. Okay, so anticholinergic, you see, you get hot and dry with big pupils. Cholinergic, toxidrome, you get smoke appeal. And killer bees, the bronchoria, bronchospasm, and bradycardia, and lung patient is wet. Like just now you see the guy on the toilet bowl. Okay, opioid toxidrome. Okay, most common features will be the bradypnea, the reduced respiratory rate. And again, the pupils is small. Hypnosedative agent, everything is down. Your BP down, your temperature is down, your pulse rate is down. Because sympathetic is everything up. You know, because why? Because sympathetic action now is all on the roof. But in practice, however, okay, so if somebody is going to commit suicide, okay, they don't pick the tablets. Okay, most of the time they go and wall up the whole thing that they can find, whatever pills that's on the table. So most of the time you see multiple co-injections, and these drugs, okay, can have additive effects to each other. For example, benzos and opioids, they can have quite prominent neurosuppressive effects, and they can render coma or reduce consciousness quickly. But in some other instances, they may have agents that might mask other effects, okay, because of their counterproductive to each other. Okay, and these patients might also have premorbids like hypertension, heart conditions, and their hemodynamic reserve might not be that great. Okay, and they also can be on a lot of medication, like beta blockers, calcium blockers that might, change their baseline physiology in the first place. So that's why toxidrome in this kind of cases might be challenging. And lastly, having said that, there's no confirmatory tests or investigations available in most of the toxidrome cases. So most of this is guesswork. So based on your clinical findings, based on your toxidrome that you encounter on the patient, based on all this, at the end of the diagnosis, then it's a guesswork that is the main feature. Okay, those, it is essential that healthcare providers have an understanding of the conditions and medications that make patients more susceptible to major toxidromes, the signs and symptoms that are likely to be seen or appear, and what monitoring parameters, interventions are appropriate for each one of these toxidromes. So that's why you have to be, not like Romeo, you have to know all the toxidrome by heart, and knowing this can save your patients and yourself in some instances. So take home messages. Toxidrome is a constellation, a group of signs and symptoms that pinpoint and that characterize the effects of the associated with exposure to a particular substance or class of substances. Knowledge is important of all these toxidrome. Okay, we described just now the anticholinergic, cholinergic, serotonin, symptomatic, stimulative opioids, alcohol withdrawal, and opioid withdrawal toxidrome. You can read them further in most of the toxicology textbooks. The presentation might be challenging to whatever I mentioned just now because of the comorbids and because of the multiple tablets that the patient might be ingested. And knowledge and understanding of these toxidromes are essential to guide the approach and treatment for this patient. So with that, I thank you.
Thank you, Dr. Mohd Hafis, for an informative sharing.